Good afternoon, everyone. My name is Song-taek Kim, working for Seoul National University. Today's my topic is management of alveolar defect for implant reinstallation. This is a scenario with the removal of the implant. The Professor Lee explained about how to manage peri-implantitis, but if we lose more bone, probably 1/3 of it, 2/3 of it, or sometimes some people say half of the length of the implant. If you lose that much of the bone, we have to consider remove the implant and place a new implant. We call this one implant reinstallation. So this is the prevalence of peri-implantitis. Peri-implantitis affects approximately 20 to 25% of patients and 10% of implant. If you place 10 implants today, you will experience next 5 to 20 years, you will find 1 of 10 implants will experience peri-implantitis. It's very high prevalence of peri-implantitis. If you see this paper, this is conducted in the dental school. Most of the residents and the students place the implant. It's much higher prevalence of peri-implantitis. 30% of patients and 20% of implant, they will experience the peri-implantitis, very high prevalence. So, as a risk factor of peri-implantitis, we first risk factor always consider smoking and oral hygiene, and also the untreated periodontitis. Some people say the history of periodontitis and also uncontrolled diabetes. These are 4 major risk factors of peri-implantitis. So, if we lose more than 50% of the bone, we can consider the implant remover. And also, if there is some progressive bone loss, we cannot stop. Then we also consider implant remover. This is one case. The people said to me, people presented with the cheek complaint with the inflammation on the implant, and he didn't have any prosthesis at the beginning. Also removed the prosthesis and came to my clinic. I found out all the implant had the bone loss, more than half of the implant length, and so we decided to remove it. If you see this video, first of all, I think the implant shoulder is facing me, aiming the outside, place too buccal. Position was wrong and the angulation was wrong. Especially this implant, I think it was placed too way buccally and also facing too outside. So long placement and also failure for the maintenance therapy. So found out this kind of bone loss around the implant. So we had to remove it. So I removed the 5 implants with strapping bar and waited and placed new implant and finished the restoration. The Seoul National University in Korea is the biggest dental hospital. So a lot of patients like this with this kind of cheek complaint visit our clinic. So we have a lot of cases. So this is the first question. So if let's say we decide to remove the implant. So when do we have to place the implant? New implant, I mean, after removal. So just remember 8 to 12 weeks. W means weeks. So just number 12 is very important. I'm gonna repeat so many times, a lot of time with the 12 weeks, because we have to consider when can we place the implant. The answer is after resolution of the chronic inflammation, and also if there is some osteogenic potential in the defect, it'll be much helpful for the newly placed implant. Therefore, for after resolution of the chronic inflammation, it takes around 8 weeks. And also, after 12 weeks, all the osteogenic potential decreased. So therefore, 8 to 12 weeks is ideal timing for the reimplantation. And also, in case of compromised defect means just like the no buccal wall and also severe inflammation. We call this one compromised defect. And also, sometimes we have to consider the immediate bone graft after implant removal. Then we have to wait more. Still, we have number 12. In this case, we have to wait 12 to 16 weeks. So 12 weeks is in common. So let's go back to the previous slide. For the resolution of the chronic inflammation and when osteogenic potential is still present, is 12 weeks, 8 to 12 weeks. And the compromised defect and simple immediate bone graft, we have to wait 12 to 16 weeks. Therefore, 12 weeks is in common. So just remember 12 weeks. It's very important. It's ideal timing for reimplantation. So this is a summary. When for reimplantation, the 12 week compromised defect, even in the compromised defect, even after the simple immediate bone graft, even after for resolution of chronic inflammation, when osteogenic potential is still present, all things we consider all these different things. So ideal timing is 12 weeks, okay? So let's summarize. Sometimes we can place the immediate reimplantation. Sometimes the mechanical complication or implant fixture fracture, then we can consider after removed implant, placing new implant at the same time, immediately. But it's not common, as Dr. Lee mentioned. So most of the failure happen because due to the periimplantitis. Therefore, this is not very common. So it's possible, but I always consider early and delayed implant placement. 8 weeks, if you want to place 8 weeks, just considering the infection-free and soft tissue healing, and 12 weeks, as I mentioned, marked reduction of the osteogenic potential after 12 weeks. So we have to place before 12 weeks. So sometimes we have to consider delayed. If we did a lot of augmentation procedure, after remove the implant, just not simple one, the augmented bone graft procedure, then we have to wait. So the literature says 6 to 9 months. 9 months. This is delayed reimplantation. So we have to consider, the defect after removal of the implant, the extraction socket of natural tooth is very something, they have something in common, but something is different. So we have to consider the healing potential of the extraction socket is high and after 8 weeks in the extraction socket of the after tooth removal, natural tooth removal. And the 12 weeks is moderate healing potential. And as I mentioned, up to 12 weeks, they have healing potential. But after 12 weeks, they don't have any healing potential in the extraction socket. So we also have 12 weeks here, okay? So it's very similar in the defect after implant removal. This is the thing. They have in common, extraction socket and the defect after implant removal. So this is the similar. And another infection resolution. The acute infection, we have to wait 4 weeks. But the chronic infection, we have to wait 8 weeks. So we have to wait about 8 weeks for the resolution of the infection in the extraction socket. I think this is also in common with the similar thing in the defect after implant removal. So this is the thing they have in common. But this one is different. Dimensional change of extraction socket. Literature says after 8 to 12 weeks, they will have major volume bone loss after tooth extraction. They will have a lot of volume change after 8 to 12 weeks. However, implant removal is different, a little bit different. I'm going to explain why it is different. Because most of the volume change, dimensional change, after removal, after extraction of the natural dentition, it happens in the alveolar process. After the major volume loss, we consider placing implant. Is correct? Therefore, after remove the implant, this is not major volume loss. Bone loss never happen after removal of the implant. That's the big difference. Volume loss is different. So timing of the implant after tooth extraction, we classify the four category: immediate, early, or late placement. But the volume loss, volume change, dimensional change is different. Therefore, for the timing of the reimplantation, we have to consider immediate or 8 to 12 weeks or 12 to 16 weeks. As I mentioned, if we consider the resolution of the inflammation or osteogenic potential, we have to wait 8 to 12 weeks. And some case, compromised defect and simple immediate bone graft, we have to wait 12 to 16 weeks. This is the difference between tooth extraction and implant removal. So just remember 12 weeks. Yeah, I'm repeating. So this is one example. We had a major bone loss around the implant here. So we had to remove the implant. After removing implant, we placed immediately the bone graft. We call this one is simple immediate bone graft. After 11 weeks, we found out all the inflammation was a resolution of the inflammation, and also soft tissue healing, and so still they have a healing potential. So we decide to place the implant every 12 weeks. Okay, this is a simple immediate bone graft. Then we consider placing implant after 12 weeks, like this. And we can see that after 20 months, we can see some remodeling around the cortical bone layer, and it's maintaining well. So this is the second question. So bone graft, most of the cases after remove the implant, we have to do the bone graft. So when do we have to do the bone graft? So immediate, sometimes I'm going to explain this. Immediate bone graft, there is two categories: immediate bone graft and the delayed bone graft. What is the difference? When do we have to do the immediate bone graft? When we have proper soft tissue management, then we consider immediate bone graft after remove the implant. And when do we have to decide the delayed bone graft? So, and if we consider the perfect soft tissue healing and resolution of the chronic inflammation, then we choose the delayed bone graft. So I'm going to explain two different procedures: simple immediate bone graft after remove the implant, and augmented immediate bone graft. This augment, I'm going to explain. This is similar to the rich preservation technique. It's contained defect. After the extract the tooth, there's contained well-defined the extraction socket. Then we can consider the rich preservation technique. And also after remove the implant, there's some well-defined containable defect. Then we can consider simple immediate bone graft. It's like very similar to the rich preservation technique. And what is augmented immediate bone graft? It's like a rich augmentation. Similar to rich augmentation, after tooth extraction, we have to consider flap advancement and also membrane stabilization. So this is two different: simple and augmented immediate bone graft. Immediate means placing bone graft immediately after implant removal. More frequently, I'm going to explain why we doing this simple immediate bone graft more frequently. So the simple immediate bone graft is just like, as I mentioned, just like a rich preservation technique, applying the osteogenesis collagen graft, bone graft material, and covering with the collagen graft too. We call this one is socket sealing. So augmented immediate bone graft is just like rich augmentation, horizontal or vertical rich augmentation, but it's wide and challenging. So after remove the implant, we are recovering, augment this defect with the bone graft and the membrane stabilization and flap advancement and primary closure. This is augmented immediate bone graft. So Dr. Lee mentioned, the Professor Lee mentioned about the prevalence of this kind of defect, peri-implantitis. Most of the peri-implantitis defect is like this. It's containable defect. You know, the horizontal defect is not, we cannot see very often this kind of horizontal bone graft. Most of the cases is the containable defect. So 68.9% is a containable defect, which means we can apply, simple immediate bone graft. And simple immediate bone graft, that's why the simple immediate bone graft is more frequent than the augmented immediate bone graft. So most of my cases in my clinic, I probably 70-80%. I always apply the bone graft immediately after the implant removal. And the procedure is very simple in the containable defect, just like rigid preservation technique. So that's the difference. Why the difference of the lesion after remove the tooth, after remove the implant, the defect is very different. After remove the natural dentition due to the periodontitis, is diffuse defect. The inflammatory spread is diffuse. Therefore, less well-defined defect is found after remove the natural tooth due to the periodontitis. And also, but around the implant, most of the cases is surface-oriented and also more well-defined. So you can remember that defect around the implant, most of them is more well-defined defect. This is one case, simple immediate bone graft. So I had to remove this implant. I don't think anybody disagree with the remove the implant because most of the bone, beyond the implant length, they lost the bone. This is line of the bone defect. So because this is well-defined defect, the granulation tissue could be removed, separated from the defect, which means we can apply the bone graft in the defect. As long as we can remove the granulation tissue perfectly, we can apply bone graft. Sometimes we can apply the implant too. However, this case, I didn't think that I could get the primary stability if we place the implant. Therefore, I decided to the immediate bone graft. So separate the granulation tissue. And as I mentioned, it's well-defined defect after implant removal. And apply the bone graft. For this case, I applied the collagen membrane. And additionally, I used the granulation tissue to cover the orifice, which means it's just like a socket sealing. So after 1 week, soft tissue healed, but a little bit, unfavorable healing. However, after 4 weeks, we can see no soft tissue defect anymore, and it's covered, well-healed ridge after 4 weeks. We call this one the granulation tissue preservation technique. Some people can think the granulation tissue has some, bacteria or some inflammation tissue. However, at the same time, they have a lot of stem cells. It's good for the healing of soft tissue and also the healing, helpful for the healing of the ridge. So after 12 weeks, always 12 weeks, after immediate bone graft, simple bone graft, 12 weeks, we placed another implant. Just like socket rigid preservation, and as I mentioned, this is a collagen graft too, the socket sealing technique, covering the orifice of the extraction socket with the collagen graft. Rigid preservation is very helpful for the anterior tooth area, for maintaining the height of free-gingival line and eventually getting the better aesthetics with maintaining the ridge with this simple procedure. So X2D is very helpful. My preference nowadays for the ridge preservation is X2D. It's denser than the X1D. It's a good thing for this material. We can suture it and stabilize it. X1D is not possible to suture itself. Instead, we are making the overlaying suture to stabilize the collagen graft. But this one, if you see, we can suture it because it's denser than the X1D. And the healing is beautiful because we can stabilize the X2D perfectly on the site. Then we can expect better healing than the X1D. So another case, if you see higher magnification, we can suture it and stabilize this cell because it's denser than the X1D. So material for the ridge preservation is collagen graft and collagenated bone. So based on the literature, there's several different ways for the socket sealing. The good thing, best thing is always a free gingiva graft. But it's painful. We have to get some soft tissue from palate. The next one is the cross-linked collagen membrane. This is the example of this cross-linked collagen membrane X1D or X2D. This is the best, and this one, non-visible membrane, non-cross-linked collagen membrane, the second best, based on the literature. And I'm not saying my experience. This is based on the literature. I just summarized it because I limit of time. And intrasocket granulation tissue, I showed one case, but it's third best. Always has some, not better than, free gingiva graft or cross-linked collagen membrane. This is one case. We found out in our clinic, in some cases we apply the non-cross-linked collagen membrane, and sometimes we apply the cross-linked collagen membrane, and the healing was best. Healing was better with the cross-linked collagen membrane, especially the soft tissue healing. We conducted animal study. We found out some difference. So in some case, when we applied the collagen graft too, the soft tissue healing was much better than the non-cross-linked collagen membrane. This is the future site for the implant placement. For the better maintenance, the soft tissue around the implant is very important, strong, and the more keratinized tissue would be more helpful. Therefore, the thick, and also we focused on the retipeg. Retipeg is the connection between the connective tissue and the epithelium, the elongated retipeg. See, and the more number of the retipeg between connective tissue and epithelium, which means the stronger soft tissue barrier. So this retipeg is very important strong connection between connective tissue and epithelium. So with this cross-linked collagen membrane, we can get the better soft tissue around the implant. That's why simple immediate bone graft, I always apply the cross-linked collagen membrane, which is X2D, X1D, collagen graft too. This is another case. So had to remove the implant with periimplantitis. So simply applied the bone graft, collagenated bone graft. I'm going to skip a little bit. And the collagen graft too. And found out after 12 weeks, the simple immediate bone graft, and found out ready for the placing implant. However, this patient never come again because probably go to some other dental office. But anyway, after 12 weeks, we can see the proper contour after implant removal. So this is another case, simple immediate. We have to remove this part of the implant and apply the simple immediate bone graft. And found out after 12 weeks, it was okay. But we applied the bone graft a lot. without the stabilization of the membrane, and found out some parts of bone loss. We didn't get enough bone for placing implant because we didn't have any membrane stabilization for just supply the simple. So augment, immediate, or delayed bone graft would have been better choice because this is a too much compromised and non-containable defect. In case of non-compromised defect, we have to consider some other procedure. This is augmented immediate bone graft, just like rich augmentation after tooth extraction. So this case, we had to remove this implant and found out, so some part is containable and some part is not containable. So you apply the bone graft and the membrane stabilization and place the implant after 10 months. For this kind of extensive bone graft, we have to wait more, not 12 weeks. We have to wait 6 months or 8 months. Implant removal and the augmented immediate bone graft and the stabilization, we have to place the implant after 10 months because this is the extensive bone graft, challenging defect, challenging procedure. This is the radiograph after immediate augmented first. I'm going to skip because we don't have enough time. So another augmented immediate bone graft for the anterior tooth area. We had to remove the implant. It's not because the periimplantitis for this case. Malposition of the implant. So therefore, anyway, we had to remove the. We had to remove the implant because it was malposition. See, we had to remove the implant and place the 10th pole for the space making, and also apply the bone graft and membrane stabilization. And also flap advancement for the primary closure. Yeah. So for the rich augmentation procedure, we have to consider. We stabilize the membrane with the suture and also maintain the space with 10th pole. We have to consider space maintaining, membrane stabilization, and also for the primary closure, flap advancement. This is augmentation procedure. Sometimes we have to consider delayed bone graft. Just wait 12 weeks. We didn't apply anything because the inflammation was too severe. We didn't consider immediate bone graft at the time. Then we can consider the delayed bone graft like this, delayed rich augmentation, and placing implant. After 6 months, we found out some augmented bone is maintained properly and place the implant like this. This delayed bone graft after removal of the implant. Let me summarize. I'm going to skip this one. This is the same delayed rich augmentation procedure. Summary. So I asked the first question, when for reimplantation, I told you just remember 12 weeks because considering the compromised defect, simple immediate bone graft, and after resolution of chronic inflammation, and when alternative potential is still present, 12 weeks. And when for bone graft, I explained the immediate bone graft or delayed bone graft. And immediate bone graft, I categorized in two: simple immediate bone graft, just like rich preservation, and augmented immediate bone graft, similar to the rich augmentation. So this is all of my presentation. Thank you for attention.